Good morning, Dental XP audience. We're welcoming you here from Alexandria, Egypt. And as you see behind me is the sea. It's a very beautiful scene, and we would like to start our presentation today about a very interesting subject, which is 3D imaging and its applications in oral implantology. And I would be glad to be with you in this presentation. Okay, here's a picture of my country, Egypt. This is a picture taken from the satellite, and as you see, it's a beautiful country. And if you go closer, here is Alexandria, the city where I live, and this is a beautiful lighthouse and the sea, and it's a really beautiful country. Okay, today our presentation is divided into these parts. We're going to start with an introduction, compare the 2D versus 3D, cone beam CT versus medical CT, or multi-detector CT, and then we're going to discuss some applications in implantology or implant surgery, and then we're going to see some clinical examples and finish by our conclusions. Okay, I think that 3D imaging has made a real revolution, and it really gives you eyes to see. Right now, the guesswork is eliminated from a lot of diagnostic equations, and what we used to speculate now we can see. And you see this example, we can start by seeing the soft tissue. If we remove it, we see the bone. If we make the selective transparency, you can even see inside the bone with implants, sinus grafts, and the prostheses. Okay, here is an interesting application of 3D imaging that was used here in my country. This is a CT scan showing a missing molar in the skull of a female mummy. This was the larger of two mummies found in a simple tomb in Egypt's Valley of the Kings. And they wanted to know which of them is King Hatshepsut's mummy. And later on, by searching the tomb, they found this box that you see here on the lower right. And this box had the name of Queen Hatshepsut on it. And this little molar here that we see, it was 3D imaged by computed tomography. It was segmented, and it was matched to the missing site here. And it was affirmed that this mummy belonged to Queen Hatshepsut. Another interesting thing is here we see the face of the mummy of the young King Tut, and later on, by doing a 3D rendering, we were able to build an approximate picture of this young king. Okay, we're going to start by comparing the 2D to 3D, and we're going to take the imaging modality, which is the panoramic versus the cone beam CT. The panoramic provides a distorted, unequal magnification and the magnified image. They're not one-to-one. While in cone beam CT or 3D imaging, even the medical CT, we have an undistorted image which has dimensions that are very accurate and one-to-one to reality. In the panoramic, we have a layer view only. You see these structures are superimposed to each other, while in the 3D imaging modalities, like here, we were able to do a 3D reconstruction, and even we can go closer and we can take cross sections, axial, coronal, and sagittal. Like this is an example to illustrate the difference between 2D and 3D imaging. This is a reformatted panoramic image, which shows this receptor site for putting implants, and it shows. But if we take a look closer at the cross sections here, after doing a cone beam CT, we can see that the bone is not as wide as you would think it, and this would make a problem while inserting the implants, and it would shift our treatment plan maybe to do expansion or so on. This is another picture illustrating it. We have an adequate height, about 18 millimeters, while the width is just 3.6 millimeters. Okay, if we compare the multi-detector CT versus cone beam CT, the main things are that the conventional CT is a fan beam, like we see here on the lower left, while the cone beam is as the name implies, is a cone beam ray, and it falls on a 2D array of detectors. And here we see the patient goes inside the CT, and the source revolves and the detector around the patient until we have a full picture. While in cone beam CT, we have this. Here is the source, and here is the detector, and it takes 180 or 360 turn around the patient, and we have the image. Okay. Another point of comparison is the contrast resolution. or here on the right we have the images from cone beam scanners, and on the left we have the images from CT scanners. And as we see, the lower resolution related to contrast here, which is the grayscale. But if we go to the geometric resolution in the X, Y, and Z plane, the cone beam CT surely has what we call an isotropic resolution, which means that this cube of volume that is imaged has equal X, Y, and Z dimensions, while in the regular CT the X and Y might be equal, but the Z is different here depending on the slice thickness or the slice pitch. Okay, so why cone beam CT? I think we can answer it by saying because it has a lower dose, because it provides an equivalent patient radiation dose which is about 1.3 to 22.7% of a comparable conventional CT, so it surely gives us a lower dose. Also, the image accuracy. The cone beam CT, as we said, have what we call a very small size submillimetric isotropic voxel resolution. It's ranging from 0.4 millimeter to as low as 0.09. So we have a better geometric or spatial resolution. Number 3 is the lower cost. CBCT equipments, they have a greatly reduced physical footprint, which is approximately 20 to 25% the cost of conventional CT. And here is an illustration of the difference between the voxel or the volume element in the. Okay, here is a picture. We have on the right of the screen the anisotropic voxel resulting from the regular multi-detector CT equipments, and here on the left we have the isotropic voxel resulting from the cone beam CT images, which leads to better 3D reconstructions that are not distorted in the Z plane and give us accurate measures and 3D bone models that we see the applications later on. Okay, going to implantology. 3D imaging has lots of application in implantology as a beginning to evaluate implant receptor sites. Number 2, planning implant position possibilities. Number 3, simulating implants, grafts, or even final prosthesis. And number 4, tracing the vital structures to prevent their injury during surgical procedures. And we're going to see each application to that. Starting application number 1, we see the measuring the bone height and width. Through the cross sections, we can measure the bone height and width and determine which kind of implants we're going to put in this place. Also, it can give us an idea about the bone density. Like here, if we see this part of cortical bone, it gives us a reading of 1051 compared to here this cortical or trabecular bone. It gives us around 62, which gives us a measure. It's not 100%, but it can give you an idea where is the hard bone and where is the soft bone when you start drilling. Another thing that's very useful to implantologists is simulating the implants, grafts, or even the final procedures. As we see in this 3D model of a maxillary bone of a full arch case, we were able to place the implants, as we're going to see with selective transparency, simulate bone grafts, sinus grafts, and placed virtual teeth to simulate the final procedures. Here we see the implants clearly placed. Here we had a fenestration and we simulated the graft upon it and the sinus graft. Okay, now the number 4, which is very important application, is tracing the vital structures to prevent their injury during surgical procedures. And the main vital structures that we have here in the mandible is the inferior alveolar nerve. And here we're able to segment it and place an implant and have a safe distance. In the maxilla, we have the maxillary sinus. Here we made a sinus graft, and here is in the case that we're going to show later, we placed an implant respecting the floor of the sinus. Number 3 is seeing arterial supply to the mandible that is not usual to people to take care of it, and you can see by any other imaging modality apart from 3D imaging. If you see here, there is a cross section in the mandible and the lingual side, and we see this canal, which is the entry of the sublingual or submandibular artery into the mandible. And if you see it here in the 3D reconstruction, and here is another illustration of this arterial supply in a dry mandible. Injury to this structure can lead to serious documented complications like hemorrhage in the floor of the mouth, and that might lead to infections, hematomas, or even suffocation in some recorded instances. Okay, we're gonna go now to some clinical examples that I did. Number 1 is the calculating the sinus graft volume preoperatively. Number 2 is an illustration of computer-aided implantology case. Okay, number 1 is the sinus graft volume calculation. We start with this video that shows the Principle to calculate sinus volume graph preoperatively. The first step is we doing a tracing of the sinus in all the coronal sections as we see here. And then we do a 3D rendering of the volume that has been traced, and we can see it here in 3D and rotated. And then the volume calculator gives us the volume, in this case it's just 20.8 centimeter cubic centimeter. And then again we can visualize this from all directions. This video just to illustrate the principle of sinus volume calculation preoperatively. In brief, here is what we did. We have a case where there is this available amount of bone. This case is for illustration. We didn't do it in reality, but to illustrate the principle. We have this amount of bone, about 8 millimeters. So if we need to do like a sinus lift in this area, we're going to do tracing in the coronal sections at the beginning till the end of the area we want to trace. And then we're going to do a 3D reconstruction of this volume that we traced, and here the volume calculator here gave us the amount, which was here about 0.4 centimeter cube of graft volume. So this is useful when you're planning your surgery and you want to know how big is the sinus, the anatomy of it, and how much bone graft you're gonna need. So if you use this technique and or other available techniques to calculate it, you'll be able to prepare beforehand the amount of bone that you need, the design, the shape. If you're doing autogenous grafts or particular grafts, you're gonna know how much you need before you start. Okay. Second example is a computer-aided implantology, which is a very interesting field that's developing. That we did here is what we call a dual scan protocol. First, we're going to start with the diagnosis and initial treatment plan. The patient came by saying, I can't eat, I don't like my smile, I don't want to remove the prosthesis, after being referred by a general dentist, and this was the condition of the dentition. She has two remaining teeth in the maxilla and lower full arch with periodontal problems and the bridge. So, by taking the medical and dental history, this was a 60-year-old female, no significant medical condition. She lost all her teeth as a result of caries and periodontitis, and we have here a bridge attached to the lower canines. She tried removable prosthesis before, but couldn't bear it and refused to have another one. So, from the diagnosis, we conclude that we have altered aesthetics, periodontal problems in the remaining maxillary teeth, and recessions. By taking a cone beam scan and doing a reformatted panoramic view, we see here a convex opacity in the left maxillary sinus and inadequate height of bone here, which complicates the implant treatment because we can do a sinus lift. She refuses it, and even if you want to do it, this probably cyst full of fluid would complicate the procedure. And we see here the connection between these two and the sinus. Is the frontal view, and we see here the deficient soft tissue due to the loss of teeth here, and same from the side. So the treatment plan was to doing rehabilitation with implant supported fixed restoration. First, we're going to do extraction of number 22 and 23 after doing after registering the vertical dimension of occlusion, and then we're going to plan to do implant supported fixed full arch restorations in the maxillary arch. For the mandibular arch, the plan is to do a full arch also prosthesis, but due to financial considerations, we're going to wait like 2 or 3 months before doing it. Okay, so we start by the pre-treatment preparations for guided surgery. Here we do our diagnostic wax up. We check the position of teeth. Here we see the difference in support of the soft tissue before the wax up and after the wax up. And then we convert this waxed up denture to a scan prosthesis. As you see in this picture, we have these balls of what we call scan markers, and here is the radiograph that they are already opaque, and we insert them in certain areas in the denture, the upper and lower one, and then we do what we call a dual scan protocol, in which we use a radiolucent prosthesis with dual scan markers. We do 2 scans, one with the patient wearing the prosthesis here, and then one of the prosthesis alone in the cone beam scanner. Of course, the advantage of this method is being quick and inexpensive when existing prosthesis can be used. And at the same time, it produces less scatter that would otherwise be produced from a fully radio-opaque prosthesis. Okay, so as we said, we did a scan with the patient wearing the appliance, then we did a second scan for the appliance alone, and then we did segmentation for the upper and lower appliances, then segmenting the patient's anatomy, as we see here, the bone, the teeth, and the lower arch, the bridge, and the teeth. And then we do a registration of the two scans together, so now we have the denture in the same place as it was in the mouth. Okay, and then we start our virtual planning in the maxilla. We plan for a virtual extraction of number 22 and 23, and here we can visualize the extraction sockets. And then we place the implants according to the prosthetic envelope that we did in the scan prosthesis, and here in the planned extraction sites. And then we take a look in all the cross sections, axial cuts, and 3D to visualize the vital structures that are being preserved, like the incisive canal here and the floor of the sinus here, and to check that everything is okay. And here you see in the slide the vital structures that were respected. Here the floor of the maxillary sinus on both sides, it's not perforated as you see in the 3D model, and the incisive canal in the center. This is the final view of the planning. And then we go to the second phase, which is the 3D printing of the surgical guide that we see here, and the drill guide keys, which have a diameters corresponding to sequential drilling drills that we use. So we start with the drill sequence, in this case the pilot and 2.0 drill, the 2.5 and the 3.2 final drill. We're going to see now a video of the computer-aided implantology case to illustrate the concepts and show a clinical example of what we've been explaining on the past case. So we're going to start by 3D planning, where we can visualize the bone in 3D, the scanning prosthesis, the teeth to be extracted, then the long axis of the implants, the abutments, and the prosthetic envelope on which we did our planning. Now we go to the day of the surgery. We're going to do an extraction of number 22 and 23. We did it virtually first on the model, and we're going to do it on the patient also, as we see now. Surely the extraction has to be as traumatic as possible to preserve the bone gently, and we have the two teeth out, and then we do curettage of the socket to take out all the periodontal ligaments, any soft tissue, any periapic lesions that might have been there. And here we see the plan and the extraction socket. Now we go to the computer-guided implant surgery. Now we go to the computer-guided implant surgery part. We have the mucosal supported surgical guide with the drill keys and the drill sequence that we're going to use, and a picture of the surgical guide in place, and the depth measurements of the implants in the bone. We start the drilling sequence by the pilot drill. Here we have it in place. Through the drill key, we do a pumping action. We make sure that the saline go through the guide so that there won't be any overheating of the bone. If the saline stops, you should stop and make sure that enough copious irrigation goes inside. Then we go to the drilling sequence of the 2.0 drill, and we do me personally, I prefer to do the 6 implants, not like finish all the drill sequence for one and then go to the other. Now we go to the drill sequence of the 2.5 drill. Again, pumping action, enough irrigation, one osteotomy after the other, making sure that the guide is in place, there is no movement in it. Some guides use securing pins that are drilled inside the bone. Now I have the paralleling pins or direction indicators to make sure that we're in the right place before doing the final drill. Also checking that all the sockets are intact, that the buccal plate of bone is intact in all the osteotomy sites. Now we go to the drilling sequence of the 3.2 drill, which was the final drill in that case. Things go smoothly and beautifully and very safe for the patient. Now we do the placing of the implants using the implant driver. In such cases, the computer-guided surgery or using these guides like reduce the time of surgery to 1/3, which was the case in this surgery. Then we do the torquing above 35 Newton centimeter, which was achievable in all the 6 implants, even the ones that were immediately placed in the 2 extraction sockets. And now we place the healing abutments in place. And in the last extraction site, we placed this wide diameter implant, and we did it gently with the hand, making sure that it doesn't slip inside the sinus, or this will do another complication, because from the previous radiographs we've seen that there is a communication between the root of that tooth and the sinus. Gently until it fits in place. It's very wide 5.8 diameter implant. We see the immediate post-operative view, clean, minimal bleeding, minimal trauma to the tissues. The post-operative x-rays in 2D and in 3D showing excellent results. Okay, here we have the paralleling pins in place, the virtual extraction that was simulated, and we see here the similarity between the virtual extraction socket and what we had in reality. As we see, it's a minimally invasive flapless surgery, minimal bleeding, minimal trauma to the patient, and beautiful immediate post-operative pictures. So in conclusion, we can say that CBCT gave us 3D images with lower dose than medical CT, excellent geometric resolution and precision, and much lower cost than the multi-detector CT medical CT equipment. And we also can conclude that cone beam CT is a valuable tool for implantologists, allowing superior diagnostics without guesswork, precision, evaluation of true anatomy of bone, precise guidance of the operative and surgical procedures. Also, computer-guided implant surgery represents a giant step forward in the replacement of dental implants, eliminating the guesswork and evaluating the receptor sites, minimally invasive, easier for the patient, diminishing the surgical time, high degree of correlation to the original plan, safety, and improved aesthetic, prosthetic, and functional outcomes of implant surgery. Thank you so much for your attention. It was a pleasure to be with you, dear Dental XP viewers, and see you in other series about cone beam CT and 3D imaging and computer-guided surgery. Thanks to all of you.